I am here to give an overview of the epidemiology and drivers of HIV in transgender communities. To begin, I would like to really start with some basic building blocks of transgender health, and that is really thinking about sex and gender identity. And when we're referring to sex, we're talking about biological differences that characterize males and females. Typically, this is sex assigned at birth, usually by a physician or the person who brings a child into the world. Gender identity refers to an internal felt sense of self as female, male, transgender, or some other diverse identity. And sex and gender identity are different. And when we're thinking about population surveillance, when we're thinking about HIV surveillance, we need to think about um, measuring both of these constructs because they do have implications in thinking about the HIV epidemic for transgender people. When we talk about transgender people, we're talking about individuals who have a gender identity that's different than their sex assigned at birth. So this includes people who are transgender, non-binary, or have some other gender diverse identity. Cisgender refers to people who have a gender identity that matches their sex assigned at birth. That is to say, cisgender being on the same side of, whereas transgender being across from. There's a great diversity in the transgender population. Celebrating diversity is an important piece of thinking about HIV prevention and thinking about the epidemic. And this is because we are looking at gender diversity as a celebration, as a piece that's non-pathologizing. And in the transgender population, we have individuals who identify as transgender women, or as trans female, trans girls. Sometimes we talk about people being on a trans feminine spectrum. So these are individuals who are assigned a male sex at birth. We have transgender men who are trans male, or trans boys if you're working with adolescents or young people. Trans masculine was a spectrum of transgender men to masculinity. And these are individuals who are assigned a female sex at birth. And then non-binary, people who feel like they're outside the traditional female male gender binary. And this could be people who identify as gender queer or gender fluid, gender expansive. Importantly, there's many different cultural specific identities. So for example, in India, hijra. In Latin America, we see the identity of travesti. There's many diverse identities. So it's very important to, when we're working in HIV globally, look at the local context to really understand the vocabulary and the terminology that's being used. And the important piece here also is that the terminology is always changing and evolving as communities change and evolve. So in order for us to be relevant and most up to date, we really need to speak to people who are on the ground. A very key construct in thinking about transgender health and also specifically HIV is gender affirmation. So for transgender people, gender affirmation is very vital, and it refers to being recognized or affirms in a person's gender. Typically, there's 4 dimensions to gender affirmation that we talk about. There probably are more, but these are the key ones that we talk about. The first is social, and this is really thinking about people's pronouns, calling people by the pronoun that they want to be referred to as, by the name that they want to be referred to as. And this is also interacting with people, social roles, social expression of gender, gender presentation. So that's a social dimension of affirmation. The psychological dimension of affirmation is really referring to a person's internal felt sense of themselves. It also can be a construct that encompasses, for example, internalized transphobia, the internalization of societal stigma. So that's an important construct in terms of being psychologically affirmed. Medically, we have different medical interventions, hormones, surgeries, body modifications. In the case of younger people, for example, adolescents, pubertal blockers. This can be a very important piece for people in order to align physically body with how one feels in one's mind. And then finally, legally. So this is things like name change or gender marker change. It's very important to note that in many places in the world, these are not possible. Legal changes of documents are not possible. And to think about how that non-affirmation impacts daily life, as well as specifically access to resources. So for example, testing and having an identification card that's not consistent with what one looks like for HIV testing may be a deterrent for people to get tested. It's also important to note that these constructs don't necessarily all align. In other words, it's not that this is a checklist that people go through in their lives who are transgender. A person can socially affirm their gender and live in their gender. They may not have a desire to medically affirm their gender. There may be people who are non binary who may medically affirm their gender, but may not live socially in their gender all the time. So there's a diversity of experiences. And this is a very important component of prevention and thinking through the factors that we need to consider. Just to be clear, when we're talking about gender identity and transgender people, this is a separate construct, though interrelated, separate construct from sexual orientation. So sexual orientation refers to how a person identifies their physical, romantic, and other emotional attractions to people. And when we look at sexual orientation among transgender people, these are some data from the U.S. What we see is that a high proportion are not identifying as straight or heterosexual. So in this particular sample, 12% are identifying as straight and the rest are not. And this is actually sort of flipped what we would see in the general population, where we might see that proportion being straight in the general population would be LGB or sexual minority. So we really do have a different distribution within transgender people. And this is very important and also has prevention implications. But transgender people can be of any sexual orientation or gender identity or expression. So in terms of the epidemiology of HIV, we do see global burden of HIV in the world, particularly among transgender women, with meta-analytic studies suggesting as high as 1 in 5 transgender women living with HIV. In this meta-analysis, a 49-fold increased odds among transgender women compared to the people of reproductive age in those countries. So we see disparate outcomes. We know less about HIV in transgender men. This is certainly an important and nascent area. We do see across studies prevalences ranging from 0 to 8%, really variable across the studies, and really the need to have more laboratory confirmed data. In terms of sexual risk, we see between 7 and 69% fluid exchange in terms of genital sexual risk with transgender men. This again is a very wide range, so it depends on how it's operationalized. And one group that we really are starting to pay more attention to and should continue to do so is transgender MSM. So that is specifically transgender men or trans masculine people who are engaging in sex with cisgender or non-transgender men. This is an important group for prevention efforts. It's also an important group in terms of an invisible and often underserved population. So we do see, for example, in the US, suboptimal testing rates among transgender women. For example, 10% in the past tested for the past 12 months compared to cisgender gay and bisexual men, 22%. We also see, for example, in a US context, disparities. That is to say, among transgender people. Here we see that Black and African American transgender people really bear the burden of new HIV diagnoses in the US. We also have differences in age. If we look globally, when we see sort of an inflection in the epidemic, where we see young people often in the sort of 20s range, and then an inflection in the epidemic increasing with HIV diagnoses thereafter. So HIV acquisition is most often, attributed to condomless sex and also needle sharing. It's important to consider that needle sharing for hormones and silicone use is something for transgender populations that's unique and that we need to pay attention to for prevention efforts. The drivers of HIV risk in transgender people are multi-level. They occur, in terms of biologically with anal sex and the high probability of transmission risk. For transgender men, there can be some risk of vaginal atrophy from hormones, which could cause more increased transmission. We have network factors, for example, high prevalence of HIV, high prevalence of HIV in sexual partnership pools. We have high risk environments such as those that are in sex work, which are driven by social and economic factors. We have community factors. We can think about stigma and social exclusion as being really key drivers of HIV infection for transgender people and HIV risk. And then, of course, structural factors. These are the contexts in which these behaviors occur in the larger context. This includes legal protections or lack of legal protections. These factors all intersect and interact together to increase risk and vulnerability. In addition, transgender people have other health disparities. So HIV is in context of other conditions. These include things like poor self-rated general health, mental health conditions like depression and anxiety, substance use and dependence, high rates of violence and victimization, delays in preventative screenings, so even other preventative screenings in addition to HIV testing, a lack of access to culturally competent care that is gender affirming and meets the needs of transgender people. And then we see a number of social conditions, and these really are around the stigma and vulnerabilities. For example, a high proportion unstable housing, poverty, and incarceration rates. And so these all together represent the different health conditions in which HIV is also situated. And so one concept that's helpful is to think about syndemics, which refers to the concentration and deleterious interaction of two or more disease or other health conditions in a population, especially as a consequence of social inequity and the unjust exercise of power. So it's that there are multiple health conditions and that these interact, and that where there is one health condition, it's intensified or enhanced, unfortunately, by others in the context of social inequity. And we do see evidence of syndemics operating in transgender populations. I'm going to show some data from transgender MSM because I did show it, because I did say that it was a group that's under discussed. So we did a study of transgender MSM in Massachusetts in the U.S. 173 individuals. About 93% identified as sexual minority, about half were on hormones and surgery, about 20% were Black, Indigenous, or people of color. And we looked at 6 indicators that we summed for syndemic: binge drinking, substance use, depression, anxiety, childhood abuse, and intimate partner violence. And what we found was that syndemics were associated with increased odds of condomless sex at the last sex that they had with a cisgender male, and that social gender affirmation moderated syndemics. So in this sample, trans MSM who had socially affirmed their gender, but not those had not, had increased risk of syndemics being associated with condomless sex. So in other words, what we found in this study is that for trans MSM, those syndemic pathways, which we have seen in research with cisgender MSM, that those syndemic pathways may be operating similarly, but that there really is a need to integrate the syndemics and gender affirmation frameworks for MSM, for trans MSM. Similarly, gender non-affirmation itself from cis male partners may be a unique risk factor. So in transgender populations, it's important to consider general risk factors that we might see in other populations, key populations, but also consider the specificity of vulnerabilities. So in another sample of 857 trans MSM that we sampled online in the US, 65% were less than age 30 years old, 28% were non-binary, identified in their gender, 33% identified as gay, 70% were white and Latinx, a majority were on hormones and had had surgery. And what we found is a scale that we made about gender non-affirmation. Some of the items, for example, on the right, where I have been mispronounced or misgendered during sex. I have crossed boundaries to validate my gender identity or expression in the sexual encounter. And we found that 78% of the 857 trans MSM reported gender non-affirmation in the last 6 months. Gender affirmation was associated, not gender non-affirmation, excuse me, was associated with higher psychological distress and anxiety, as well as lower odds of HIV testing and higher odds of past 6-month condomless receptive sex. So this need to consider gender non-affirmation and how that may drive HIV risk behaviors. In this sample, we looked specifically also at 843 HIV negative MSM that were within the sample. And one of the things to think about is pre-exposure prophylaxis and the uptake of PrEP and other biomedical prevention strategies in trans communities. In this sample, 84% had heard of PrEP. Of these, about 1/3 reported lifetime PrEP use. 55% overall were PrEP indicated. I'm showing you on the right a schema that is through the any PrEP indication as defined by the Centers for Disease Control in the US. And one of the issues is also how do we measure PrEP indication in transgender populations? What are the metrics? Do we use heterosexual PrEP indication? Do we use MSM PrEP indication? So in this, we combined measures of multiple different indications, and we found that about half, 55.2%, were PrEP indicated, and that factors that associated with PrEP indication were being gay identified versus not, psychological distress, hazardous alcohol use, and polydrug use, so some mental health variables, higher perceived HIV risk, which we've seen in other populations, and also a unique impact of stigma by a cisgender male sex partner, so using that scale from the prior slide. So in summary, when we look at the HIV epidemic and drivers in transgender and gender diverse populations, what we see is a high burden of HIV disease. We see a vulnerable population in need of resources for prevention and care. We see that drivers of vulnerability occur at multiple different levels, ranging from the individual sort of biological level to the community and structural levels. We see how syndemics and other health disparities co-occur, and we see how these also influence the pathways of the HIV epidemic. It's also important when we look at transgender HIV that we think about gender affirmation and the key role that this plays in the epidemic and the specificity of transgender experiences. And finally, it's critical that we engage transgender and gender diverse communities. Without doing so, we won't understand even the basic terminology, and we won't be able to really identify the true engagement that we need for transgender people. And so when we think about the HIV prevention strategies, we do need combination prevention interventions. And this ultimately will be the way that we can address the HIV epidemic among transgender people. Using a participatory population perspective, we can work with and not on transgender communities, and doing so will enable us to really be able to tailor the combination approaches for this specific population. Thank you very much. Here is my contact information, so please feel free to reach out. Delighted to be here. Thank you.